If I would ask you GBS, what are the things that come to your mind with GBS, Ruchika? Say I ask you what is GBS, so what would you probably say?
So loss of sort of a paralysis, loss of reflexes,
Okay.
or decreased reflexes, and slowly the patient worsens neurologically. And
Anything else? Anything else? Anybody wants to talk about GBS? Demyelinating. So she said demyelinating. Okay. Then, so she said few important things. She said it's paralysis. Then the next thing that she said was there is deep tendon reflexes are lost. You said it is ascending. Any other words that represents GBS? Any other words that
symmetrical involvement?
One word that she said was weakness. She said paralysis. You said symmetric. He said demyelination.
Ascending.
He said ascending. Ascending. Okay. Anything further? After an infection, post-infectious. Okay. So there are many things that come to your mind when you talk about GBS. GBS is not a disease. It is a syndrome. That's why it's called as Guillain-Barré syndrome. And this Guillain-Barré syndrome, under it has got few of the nerve or muscle-related issues. Now, under it, the commonest GBS muscle-related syndrome is AIDP. So you don't write. Close your books, basically. Okay, let's just listen. Okay, so GBS, if you think about GBS, the commonest thing that should come to your mind should be AIDP, acute inflammatory demyelinating polyneuropathy. This is the commonest thing that should come to your mind, and majority of the cases that come into the ICU with GBS would be acute inflammatory demyelinating polyneuropathy. Okay, so in that entire umbrella term GBS, there is AIDP. The other variety that we can talk about is acute motor axonal neuropathy. Now, what is the difference between both of these things? In acute inflammatory demyelinating polyneuropathy, you have the inflammation that is directed against the myelin sheath. That's why it's called acute inflammatory demyelinating. Okay, so that means all the inflammation is directed towards the myelin sheath. Okay, so myelin sheath is responsible for movement of nerve conduction velocity, nerve conduction. Nerve conduction, myelin sheath is there, that's why nerve conduction takes place. Right? So, when you do a nerve conduction study, you will find the conduction velocities to be on the lower side. Simple. Clear? Acute inflammatory demyelinating polyneuropathy, if you do a nerve conduction study, you will probably find that the conduction velocities are on the lower side. Understood? Acute inflammatory. Whereas the other variety that we talked about is acute motor axonal neuropathy. So, what do you think this should be? What do you think this should be? The inflammation is directed towards, there the inflammation was directed towards the myelin sheath. Here the inflammation is directed towards axons. Here the inflammation is directed towards the axons. So what happens over here is the compound motor action potential itself comes down. The motor action potential itself comes down. Clear on this? There the motor action potentials will be preserved. Whereas here the motor action potentials are going to come down, but conduction velocities will probably be preserved. Clear? Because myelin is not affected there. Clear? Now since here it is axonal, that is the central cylinder of the entire nerve, this has got a worse prognosis as compared to that variety that we call as acute inflammatory demyelinating polyneuropathy. Clear? This much is clear? So we talked about acute inflammatory demyelinating polyneuropathy. We understood what is acute motor axonal neuropathy. The next variety is acute motor sensory axonal neuropathy, where even the motor system is involved and the sensory system is involved. This has got the worst prognosis. Okay, this has got the worst prognosis. Okay, among all these, this has got the worst prognosis. So, are there only 3 varieties? No, there are more varieties in GBS. There is something called as Bickerstaff encephalitis, which also presents like GBS. There is also something called as faciobranchial or cervical weakness. That is also part of GBS. So there are multiple syndromes, but these are rare. Like the Miller-Fisher variant is rare. Miller Fisher variant is also there, which includes ophthalmoplegia with all these things that comes in. Okay, facial paralysis and all these things. That's Miller Fisher variant. But those are all rare. What is common? Acute inflammatory demyelinating polyneuropathy. So say I have a patient that has come into you. Okay. So what are the histories that you would like to elicit in these cases? What are the histories? The first history that you want to figure out is how did this start? How did this start? What kya hua kya? So what do you expect this patient to tell you in acute inflammatory demyelinating polyneuropathy? What do you expect this patient to tell you?
Some history of infection.
So exactly. So they might say, there was a history of diarrhea. There might be a history of now COVID. There might be a history of some viral illness. Something is going to be there mostly. Not as a rule. It has to be there. It can be there. Okay, which points towards the more difficult varieties of GBS. Okay, so GBS can come even without all these things. Alright, so this will be one history. You will take a history of HIV, you will take a history of rest of the problems. Okay, drug intakes. There is a lot of other things you will take into apart from the infective part of the entire story. Then what will be the other history that will probably the patient will give you? How does the weakness come in? How does it go in? So you'll classically say that I will have paresthesia, I have sensation mein problem my fingers and toes mein. It starts like that. Okay, so fingers, toes, sensations becomes a problem. That is paresthesia that develops, and then it follows by muscle weakness. Clear? Then it follows with muscle weakness. That means you will then say my legs I don't feel I have power in my legs and I can't move my legs. So it is generally ascending in nature, as someone rightly said. So it ascends upwards. And generally it is symmetrical. That means the weakness will come in, it will be symmetrical. Okay, it will be symmetrical and it will ascend upwards. Clear on this? Clear on this? Now, as it ascends upwards, the variety that is acute inflammatory demyelinating polyneuropathy will also have a loss of deep tendon reflexes. Okay, which is classical. Which is very classical. There is a loss of deep tendon reflexes that you might see much earlier in the motor axonal variety as compared to the rest of the varieties. AMA, that is acute motor axonal neuropathy, acute motor sensory axonal neuropathy will have deep tendon reflexes going off much earlier than the AIDP variety. Okay, but classical finding for GBS is the loss of deep tendon reflexes. So you need to check the reflexes of these particular patients: knee jerk reflex, ankle reflex, elbow reflex, triceps, and all these things you need to look at to figure out whether there is a loss of deep tendon reflexes. Clear? The other thing that the patient might tell you is, I am experiencing hot flushes, I feel my heart going very fast, I get palpitations. Okay, what are these?
Autonomic symptoms.
Yeah, so they can be autonomic symptoms. The patient's relative might say suddenly उसका पूरा शरीर लाल हो जाता है. He becomes facial flushing. He gets facial flushing. So these are all autonomic symptoms that you may see in these patients. And these autonomic symptoms can be so difficult and so dangerous that it might lead to severe hypertension, severe hypotension, extreme tachycardia or extreme bradycardia. It can go to any part. And because of those symptoms, you may have the patient developing Takotsubo's cardiomyopathy, like the heart suddenly dilates, there is LV failure, and patient may come with breathlessness. It may be a GBS that is actually presenting with Takotsubo's cardiomyopathy because they have extreme autonomic fluctuations. Are you getting the story? So there is a possibility that the patient might say, मैं कल थोड़ा weakness लग रहा था कि रात में कुछ श्वास नहीं हो रहा है. So you should not just assume that the ascending paralysis has occurred. When you do a DTR, it is important for you to do a 2D echo because the autonomic hyperreactivity, the autonomic dysautonomia that it is causing, may cause an activation of the sympathetic systems, causing Takotsubo's cardiomyopathy and LV failure. Alright. Classically, these patients are conscious and obeying commands. Now you have a patient who comes in who is absolutely like as if he's not moving, nothing at all, come down, can't see, suddenly blindness. This could be a part of. Say you have a patient who is diagnosed GBS in the wards, who is getting treated, now comes to you with blindness. What is your thinking?
Retinal hemorrhage due to hypertension.
Okay, so
Accident.
but that will cause curtain across the eyes. It doesn't cause, it's generally not bilateral, it's unilateral. Normally it's not bilateral. It's not associated with GBS. So if you have a patient in the wards being treated for GBS and you get a call saying that this patient is suddenly behaving weird, okay, and is having and he can't see since morning hours. From where? What? So when you have dysautonomia, there is always the entity called as posterior reversible leukoencephalopathy or PRESS. Okay, so these patients can be in the wards because it was doing okay. It's a very confusing situation. Patient coming from the wards and then you diagnose PRESS. PRESS occurs because of very high blood pressure fluctuations. So very high blood pressure can lead to posterior reversible leukoencephalopathy, which is a MRI diagnosis. Clear? So there are various manifestations that will come. Agitation and delirium is a part of the sympathetic overdrive. So if a patient comes with agitation and delirium, it's a part of the sympathetic overdrive. It is because of this patient having dysautonomic symptoms. Clear? So these are the various symptoms that the patient will come in with. What will you do? You will look at cranial nerves. It's important that you look at gag reflex. It is important that you look at corneal reflex. You look at all the reflexes from the cranium, because the facial-brachial weakness type will show all those cranial muscle weakness. Okay, the acute motor axonal may show only facial muscle weakness. Okay, and AIDP may not show you any cranial nerve weakness. Are you understanding? So different varieties may show different weaknesses. Now, why are you doing that? Because you know that the Aman variety and the Axon variety have got worst prognosis. They have got worst prognosis. That's why you know for certainty I have a reasonable estimate that this patient can. So which are those patients that have worst prognosis? The Axon variety followed by the Aman variety. That is the acute motor sensory axonal neuropathy and the acute motor axonal neuropathy. The second patients that worsen very quickly are those who have already rapid worsening. Usually, what is the usual course of the disease? Can anyone tell me what is the usual course of the disease, the spread of the weakness? Exactly. So what happens in these cases is that you have the weakness developing a while ago and it reaches a peak of weakness by somewhere around 2 weeks. So your history taking becomes very, very, very important. Okay, so if the patient says I had weakness yesterday and today is kind of paralyzed from the lower limbs, you can expect that this is very rapidly progressive, extremely rapidly progressive. Are you understanding? You are not expecting that at all. Okay, you are expecting it to slowly peak at 2 weeks and some varieties at 4 weeks. Okay, but not early. Are you understanding? So it reaches a peak, then remains stable, and then slowly starts improving over a period of months. Clear on this? So if your history says, I was okay till 3 days ago, 3 days ago I developed a weakness, and now weakness is such that he's not moving his legs, I am looking at a rapidly progressive disease. I need to act a little bit more faster. Okay, this patient may go down with all kind of problems. And what am I worried about? I am worried about his respiratory system. Now, how do I predict that this patient is going to lose his respiratory system? A, from the history, that I will know that this patient is rapidly progressing. But how do I do it clinically? For example, you are called to the ward. You have a patient of GBS. Okay, you are called to the ward. And there is a very important question that the consultant is asking. Patient kaisa hai? A very important question. Everyone will ask you, patient kaisa hai? This is the first one. How is the patient? So you will have to give him an idea how severe the patient is and does this patient require the ICU? Because otherwise the patient is normal. No? Otherwise the patient is quite normal. Patient is actually looking and talking to you. Question is, does this patient require to come to the ICU because I am expecting a respiratory failure? How do I do that? A, from the history. Okay, that this is rapidly progressing. You find it out rapidly. Second, any tests that you know.
Single breath count.
So single breath count. What is a single breath count? It is extremely effort dependent. A single breath count is not a function of the respiratory system. It is a cardiopulmonary system. It is a single breath count. Are you understanding? It is cardiopulmonary failure. For example, if you have a patient who is having just respiratory failure, a single breath count is not something that will probably give you the right answer. Are you understanding? So what is the test that you would probably want to do in these cases? What am I worried about?
Respiratory muscle barre.
Which muscle is most important?
Diaphragm.
80% of our respiration occurs on the diaphragm. So I need to figure out something that will give me a reasonable estimate about the diaphragm, the expiratory muscles, and the compliance of the lung. There are three things that I'm worried about. What are the three things? Inspiratory muscles, expiratory muscles, and the compliance of the lung. Anything of these problems is going to cause an issue. Which is the pulmonary function test that tells me all three? Forced vital capacity. The answer is forced vital capacity. So, the answer to understanding whether this patient will require an ICU is probably doing a forced vital capacity, which basically means taking a deep breath and exhaling as much as possible. Okay, so it gives you the inspiration, gives you the expiration, and gives you the lung compliance. Okay, what is normal? 60 ml a kilogram. The answer is 60 ml a kilogram. That's normal. 60 ml a kilogram is normal. Okay, anything less than 30 has got a high chance that patient will may require an ICU. So the transfer to the ICU can be based A on the forced vital capacity, if you can do the forced vital capacity on the bedside. You have a machine to do forced vital capacity and you forced vital capacity. Second, negative inspiratory force. Again effort dependent. Again a test that is very, very effort dependent. Okay, that means to say the patient has to take a deep breath and if he is unable to take that deep breath, the negative inspiratory force is less, which actually is the value that is responsible for coughing. If you want to cough properly and exhale properly, you need a good negative inspiratory force. Right? So this is the other test that probably you can look at. However, these are two things that we can't do in our hospitals. That is why it's a pure clinical call that you need to take at that particular moment. And the most important value of all this is which? Is your history taking. Because we are not doing forced vital capacity, can you? Okay. So forced vital capacity and negative inspiratory force becomes the most important thing that you can look at. What about a blood gas? So it's very, 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 very terminal. If you start getting CO2 retention and a hypoxia, you have missed everything. You have missed literally everything. Okay?
Patient will also show symptoms.
Will not show any symptom. Issue is this. Issue is what? This patient is not going to show you any symptom. He's just going to be lying down aram. He can't be breathless because he's got muscle weakness. You understand? He will not be showing anything. He will be just lying down like that there. If you leave him like that, he will arrest because carbon dioxide he will become more and more drowsier, more and more down, and he will arrest. Respiratory arrest. You understand? So he's not good. That is why it is a very difficult proposition. It is a very difficult proposition when you see a patient in the ward. If he is breathless, you see whether there is other cause causing breathlessness here, whether there is Takotsubo coming in, whether there is developed a pleural effusion because of lying down for a long period of time. Are you understanding? If he's just lying down over there and he's slightly drowsy than yesterday, you should think, okay, this might be the terminal stage. We need to quickly move the patient. If you have gone to a situation where you see a blood gas or you see a saturation drop, you are beyond. You are going to take these patients much before that to your ICU. Clear? Now, important part. What happens to the bowel and bladder? What happens? Usually there is no problem with bowel and bladder. Usually there is no problem with bowel and bladder. That means they will not have retention of urine. They will not have a bowel and bladder constipation. They will not have these. If they start having these, means either it is a very worse variety and you will have to rule out other pathologies which include spinal cord issues. You understand? So it is not regular to have bowel and bladder instability with respect to GPS. They are not regular. But it can occur in the very severe varieties. Okay, very rarely it can occur in very severe varieties. However, if it occurs in a variety that you feel is not very severe, then you should probably think of something in the spinal cord. Right? And in that spinal cord, when you do an MRI, you might get some space occupying lesion or something which is unlikely to be GPS, space occupying lesion and all. or something like that. Sometimes you may have the anterior horn cells to be more lighting up in the T2 imaging, which also is a part of spinal GBS. Is also a part of GBS. Clear? Now what happens to CSF? Do you want to do a CSF here? Why? Patient is fully conscious obeying commands. What is this thing? What is this thing? What is this thing? What did you say? So you said the word right. Albuminopsychologic. So what is this? So what happens in GBS is when you actually do a CSF, you may find the albumins to be more than normal. Normal is 50. You may find it to be more than normal, and the cytology to be slightly elevated, not equal to the protein going up. Usually, what you want, protein going up, cells going up. That is what is meningitis, isn't it? You have cells going up to more than thousands or 100, 200s and 300s, and protein also going up. This is what you see. But here, what is happening is you have the proteins going up, but the cells are not going up as much. It is 100, 50. Okay, it's not going up. This is called albuminopsychologic dissociation. Clear? Like for example, when you say meningitis, you find proteins going up, you find cells more than 2000, you find glucose less than 40. The classical sign for bacterial meningitis is sugars of CSF being 34, WBC count being more than 2000, of which neutrophils is 1180, that is a cutoff. Neutrophils 1180, and sugars being less than 34. 34 or less than 34 milligram per dl. Ideally less than 40% of the serum. Whereas in this, what you will see, rest everything will be normal. All that you find is the protein going slightly higher and the cells not going higher. 100, 50, above more than 5. What is normal? Less than 5. Less than 5 cells are normal. This will be more, 50, 60. You got the point? So albuminocytologic dissociation. So there are also certain tests that you can send via the CSF, and of which one of the tests that you probably want to send is oligoclonal antibodies. Okay, oligoclonal antibodies. So what is happening in GBS? There are antibodies that are directed towards the GM1, GM2 membrane, the endocyte membrane, GM1, GM2, GM3. These are a set of antibodies that are against these particular receptors. Okay, so you can test this particular CSF for all of these antibodies, anti-ganglioside 1, M1, M2, GTP1, there are many antibodies that you can test these CSF for. But that is not confirmatory in any way. It is confirmatory in any way. Okay, it is not to be done on a regular basis. It is not required. And moreover, this will not occur in the first 3-4 days of GBS. This is going to occur only after 7 or 8 days. Okay. However, if you have suspicion that this is probably not GBS, this is encephalitis or meningitis from some meningoencephalitis from some viral etiology. Like for example, you have anterior horn affected by human herpes virus. He has got herpes zoster, okay, or herpes, and you find the anterior horn cells to be affected, which causes also weakness of the lower body. A viral pathology which can cause anterior horn cells to be weakened, which causes weakening of the lower limbs. Okay, here again patient is presenting like GBS because usko lower limb weakness hai, but the anterior horn cells are involved. This is a viral pathology, and there I am suspecting something else. I probably do a CSF there to figure out whether this is human herpes virus. You understand, the HSV. You understand? Or for that matter, this patient came blind to us, like our patient who came, and flickering blindness that has come and gone. Okay, and there you want to rule out multiple sclerosis. So CSF will give you that kind of a picture where it shows double oligoclonal band, things like that when you look at multiple sclerosis. Classically, this CSF was done classically to distinguish GBS from polio. Classically. Okay, that means that at that stage when there was polio happening, they should do a CSF to figure out this is polio or this is GBS. Are you understanding? It is very, because it's so common, GBS is actually so common among the neuromuscular disorders that you need to distinguish at that time, because polio was also there, which proved very similar to this. Are you understanding? So CSF, would you do now? I don't think so, unless I feel that the patient is more than 15 days old in the disease and patient has got these things. Now in which cases you will not get this kind of albumin-cytologic dissociation in HIV. That's why a triple H is usually done in these cases if you are doing a CSF. In HIV, you will not find albumin-cytologic dissociation. You may not get that. You understand? You may get lymphocytological dissociation. That means you get lymphocytes going up slightly. Clear? Huh? Clear on this? Huh? So the CSF per se, would you probably do it? No, I will not want to do it. Okay? And if I do it, I want to do it completely. If I do it, it means I'm thinking not of GBS, I'm thinking of some other disease. So I will do it. Once I do it, I want to do it for everything. Bacterial meningitis, viral, fungal, TB, everything I want to do it. Creutzfeldt-Jakob disease, West Hand fever, everything I want to do it. Are you understanding? So if I go to send a CSF, you should be clear to send everything possible in that. Because you're now looking at something else only, you're looking at a completely different disease entity. Clear? Clear on this? Okay. Now we have this patient who's come in with GBS and you feel that this patient is probably doing well. But you feel that his respiration system is not okay. The basic problem with GBS that we face is atelectasis. There is a basic problem that we face with GBS. The basic problem is atelectasis. So there is, it is reasonably certain that you can probably give a non-invasive ventilation if the patient is not able to do his physiotherapy. He will not be able to do physiotherapy. That's why the non-invasive ventilator makes a big difference, world of a difference in these patients because it avoids the atelectasis that comes along with it. If the patient requires an intubation, patient requires an intubation. Okay, and the criteria would be actually a clinical criteria to see how bad he is getting. So you immediately intubate this patient. NIV may not work. NIV is always a bridge to intubation. You understand? Because this disease is not going to heal the third day. You are understanding? ऐसा नहीं कि when I get tomorrow is going to heal, it's going to progress with it. Because you know the progression occurs up to 2 weeks. You understand? So if the patient has come in 5th day and required NIV, you have a very low threshold to intubate this patient. The chances of patient going on a ventilator are very, very high. You are understanding? Because there is no point of just continuing NIV. You will develop aspiration pneumonia, you will develop atelectasis and die. Are you understanding? So that's a very, very important clinical call that you have to take when you have a GBS patient. Now the question that comes is, okay, you have, there are many problems that come with GBS, many problems. For example, because of the sensory issues that come in with GBS, sensory paresthesia, they have a lot of pain also. They have got a lot of pain because the nerves are affected. They have a lot of pain. Now, if this patient is in front of you and you have pain, this patient is screaming in pain, what do you do? What do you give? How will you manage this? So she's going to give pregabalin. What about you, Elizabeth? Fentanyl. What about Namrata? Fentanyl. How many people are going to say that they're going to give pregabalin? Hands up. So Sachin and Alia. How many people are saying we give fentanyl? 1, 2, 3, 4. 4 of you or 5 of you. Okay. Any other drug? So here is the biggest issue. When the patient has got pain, how do you treat these patients? Now, an opioid per se is going to cause some amount of respiratory depression. So you will not know whether it is the opioid causing the respiratory depression or is it his worsening system that is happening. Because this patient is no longer a patient in the ward. The patient in the ICU is coming with a situation where he can't breathe, where he is going slower and slower and slower. The metric is respiratory rate. Okay. Now, if you give opioid, the chances are that the respiratory depression will occur further. So opioid per se is not a great drug I would probably want to use. I want to give him a drug that will not put the patient to sleep, at the same time take care of the nerves. So you said right about neuropathic pain, but unfortunately sometimes pregabalin may cause a little bit of drowsiness, which can be quite dangerous in these patients. So one of the drugs that you can trial and test first of all is always paracetamol. It is important that you always talk about paracetamol because it's a very safe drug to be given in these patients. Very safe. Paracetamol is so safe that you can give to pregnant ladies, isn't it? So paracetamol is the safest drug you can use. So say the simple things first. Okay? And then the next drug that probably you want to use is gabapentin. Neuropathic pain. So gabapentin can be tried. Pregabalin, yes, in small doses you can have. Gabapentin is probably something that you will want to use in these cases. So, as a knee jerk, what happens is when you are in the ICU, pain or a fentanyl in the photo, that is not the way it should work in this case. Okay, now let me give you a scenario. This patient is in the ICU, okay, and you have gone ahead and put the patient on an NIV and you find the blood pressure to be 240. Now what do you do? What do you do?
Pain.
So you're given the pain relief. I mean, she decided to give gabapentin, you gave gabapentin, you gave gabapentin, and now patient is in a situation where his blood pressure is 240.
Nothing.
So one part, that is what is your come on. Come on.
So I'll keep the patient on a low dose NTG as well as the noradrenaline also ready because the patient can have autonomic insulin.
So
Sir, I will give whatever routine medication, antihypertensive correctly, but I can't start NTG.
who you
Just monitor, sir, for some time.
will monitor. Sachin,
Sir, even I'll observe her sometimes.
you will observe.
NTG, sir.
So what they are saying is right. You will probably observe. You will observe because this might be related to a small dysfunction that has occurred autonomically, and you will observe. The very likelihood is that within some minutes, within some 10 minutes or 5 minutes or so, there is going to be a drop and everything is going to become okay. This is autonomic dysfunction. You understand? So, very high likelihood that things will just settle down. Give time. If you in a hurry go and give NTG and all these things, it can go from up to rapid down and will not come back up because of the dysautonomia that he has. So it's a very difficult predicament. If you ask me 220, 230, what do I do? And I have to keep observing. What do I observe? I do an ultrasound. I look at pulmonary edema. Is it developing? Is he developing signs of hypertensive encephalopathy? Is he having flaps? Is the patient getting disoriented? Is he getting so it's so difficult to actually look at all these things. And you ensure that patient does not have a hypertensive urgency or emergency. Okay, if that starts developing, you have no option but to actually control it with a small dose of a short-acting agent under continuous monitoring. And that can be quite disastrous because you give that, there can be a drop in blood pressure and then things cannot improve. Right? So classically, what you have these patients is a huge amount of deterioration, and then it starts improving. So it's a monophasic kind of illness. It's not biphasic. Deterioration, improvement, deterioration, improvement. It will never occur like that. It is usually a monophasic kind of a disease. Our entire attempt is to prevent further progression. Our entire attempt is to prevent further progression of this particular disease. You are understanding? So GBS is a disease of intensive care if you ask me. Okay, they have to work very hard at this time because the entire success of this particular is teamwork. The nurse, the doctor, the psychologist, counselor, everyone together working together only can improve a GBS patient. They go psychologically down, they become. Now if this patient has got a course which is just going down, and that improvement is not being seen after 4 weeks also. That means you are dealing with chronic inflammatory demyelinating polyneuropathy. That will be a generalized dhire weakness only. So you have certain cases of GBS that then goes into CIDP and these patients don't improve. They go on slowly but steadily worsening. Years and years they keep worsening, they never get up from their beds. They become slow, going down. This is CIDP. Understand? Okay, so in short, when you have a differential diagnosis in your mind of these patients who come to you, you should have everything right from anything that can cause problems to the spinal cord. Okay, you should have everything in your mind. So that's why you have to rule out these things like infective pathology, malignant pathology, and autoimmune pathology. These are the things that you should be ruling out. Okay, when a patient comes, you should that requires very good history taking and examination of this particular patient. Clear? So you have to rule out something like transverse myelitis and things like that in these cases. Clear? You have to rule out all these things because they can be very similar. They can look very similar to GPS. We already studied about IVIG and plasmapheresis the other day, and we decided that we probably use IVIG in these particular cases. Or plasmapheresis both being effective, but IVIG because of the fact that you don't need lines and tubes, then you do IVIG. Right? Any questions on GBS? GBS is simple, not a difficult pathology at all. Any questions on GBS?
So since GBS is a diagnosis, like we exclude other things, right? So Like, should we be imaging the brain and the spine as a routine? Like, should we check for any spine?
If you think that you're dealing with something different, the history is not. See, patient has come in. Patient has got bowel and bladder in balance suddenly. Now this can't be GBS. You understanding? Patient has got a sensory as well as a motor level. Suddenly, a level. That is acute transverse myelitis. Patient is showing signs of drowsiness and dizziness. I'm not okay. I'm not cognitively down. It is encephalitis. Patient is having a rash somewhere and associated with all these things. There is a possibility of herpes causing something like this. So Lyme's disease. There are target lesions on the body. That's Lyme's disease. There is some skin disease that is you're seeing. It's Lyme's disease. It's not GBS. So you will do it in only those cases in which you feel that there is an alternative pathology. You understand? And that will require you to examine this patient very, very carefully. Okay?
Sir, what about EMG? In every case, we have to do it, or we have to take clinical call.
So the diagnosis is not based on electromyography. The diagnosis is based on the fact that you have classical signs and symptoms of which there has to be symmetrical muscle weakness of more than one limb. An ascending kind of paralysis. You understand now? So diagnosis is not based on EMG. EMG and NCV are corroborative. So absence of deep tendon reflexes, okay, progressive weakness, and no other clear explanation for these findings. So it's like a diagnosis of
Exclusion.
You understand? Clear on this?
Sir, our patient post the COVID patient Shalaka, I think she had.
Yes, she had done. So clear on this? So if I were to ask now that we learned all these things, I will give you a history. You tell me whether this could be GBS or cannot be GBS. Okay. So I had weakness yesterday. I was okay till the day before yesterday, and today I was shifted to the hospital yesterday because I was having weakness of both my limbs. Okay, that is 3 days ago. 3 days ago. Yesterday the neurologist has seen and given me IVIG. But I still don't. I feel much better today. I feel much better today, and my weakness is looking. My weakness, I think, has improved. Today is day 4. Well, I received IVIG there. Okay, and today is day 4, and my weakness is kind of improved now. What is this? Is this GBS? What is this? Very cool. You got the point? What I went outside with my friends. And I went hiking to a place, and I came back. And yesterday I had a little bit of 4 days ago I had a little bit of diarrhea. I was okay, but I started getting weak. My lower limbs, I started getting weak. So I came to the hospital. My doctor has started me on IVIG, and I feel fantastic now. It's day 3 now, and I feel fantastic now. My weakness is kind of markedly improved. You got the point? Thank you. So what is this?
Can be Lyme's.
Can progress.
Lyme's. Not a GBS, but
Not a GBS.
Not a
Why you say not a GBS?
so because there is an improvement after IVIG, so
So the question now comes to you all is, so what is the question? What is the question is, why is it not GBS? Why is it not GBS? Because what happens, as I told you, there is going to be a steep fall in the entire thing over 2 to 4 weeks classically. Disease will halt there, and then the improvement starts for maybe weeks, after 1 or 2 weeks. It's not today I get IVIG, tomorrow I'm standing up. You got the point? That is less likely. It is less likely to be GBS. Clear? Clear? So the classical feature is, you have this patient who is coming in from outside. He progressively weakens in 2 to 4 weeks. You give these medicines, the weakness stalls maybe at 10 days and 11 days, it may stall at 5 days, it may stall at 6 days. But he will not improve immediately. It's going to take a while for him to improve. The nerves are spoiled, it is not magic. The nerve has to regenerate, the nerve has to take out. It's going to take a while for that. So, even 4-5 days later, you will see this patient getting much better. Clear? Clear? Now let me give you another scenario. Okay. I went for this hiking trip and I came back from the hiking trip. My left hand is showing extreme tingling numbness and I can't feel this very well in here. And my toes also I am feeling. My left toe and second toe is also showing this kind of sensory loss that I am getting. And I am feeling now weak. I started feeling weak. What am I doing?
Only
Again, the problem is here is when you have sensory weakness, it usually is symmetrical. So if you have non-symmetrical, this again this goes on to say that
It's not
Not
GBS.
okay. So I have another patient. I have a patient who comes in with okay. So let's see. I was okay till some days ago, and my entire sensations have gone. I'm also having problems in passing urine and stool, and I've become extremely weak. My lower limbs I can't move, and I think I can feel everything till here. After this, I can't feel anything. So this is not GBS. Because you have a fixed level here. You have a fixed level here. You have bowel and bladder incontinence. This is something else. This is not GBS. Clear? So, in short, GBS is a clinical diagnosis. You have to exclude everything else, and then you come to a conclusion as to what GBS is all about. Clear? So you should be very careful. That's why you do reflexes to understand how to do the reflexes. Because the actual patient will never understand what is reflex. If you don't do the deep-fitted reflexes in normal people, you will never know what is an abnormal reflex. Are you understanding? Clear?